Ischemic heart disease is going to be the topic of this presentation. Students oftentimes find that this topic is complex and difficult to wrap their heads around. So my intention and goal with this particular lecture is to simplify things without missing any of the details necessary to do well in the USMLE Step 2. So this is going to be part 1 of a few parts to discuss ischemic heart disease. And in this particular one, we're going to talk about myocardial ischemia. And let's go ahead and get started. So myocardial ischemia, this is a story of supply versus demand. And the story of supply and demand of coronary artery oxygen supply can be limited by coronary atherosclerosis and hypotension. So let's look at Mona Lisa here. You can see the characteristic look of a patient who has chest pain. She's putting her fist to her chest like someone experiencing really bad chest pain associated with ischemic heart disease. Now, from my previous lecture on chest pain, we know that not all chest pain is ischemic heart disease, but we want to rule out the most dangerous and life-threatening illnesses when doing our differential diagnoses of chest pain. The topic of this lecture is going to be myocardial ischemia, so we're going to be focusing on myocardial ischemia being the cause of this chest pain. But she's doing some interesting things with her hand, and you can see in her eyes. If she were taking a walk or running down the halls of the Louvre, where she resides today, we'd call this demand ischemia. I'm going to repeat that, demand ischemia, and say that she's experiencing something called stable angina. If she was just hanging out in her frame in the Louvre and not putting any demand on her heart muscle, she'd either be experiencing something called unstable angina, or perhaps she could be having an infarction, or what we oftentimes call a heart attack. So again, you can see the red circle around the characteristic hand or fist over the chest. Sometimes patients say that they feel like an elephant is sitting on their chest or extreme pressure. I'll talk a little bit about the symptomology, what patients experience when they have this kind of chest pain. We'll go through everything from the risk factors that lead to ischemic myocardium or ischemic muscle, and we'll go from there. So when you look at this slide, what you see here are atherosclerotic plaques within the vasculature. On the left, you see the blood vessel or the coronary artery with a clear lumen. The inside of the vessel is clear. But when you look at the right side, you can see lipid deposits of plaque. And when you have lipid deposits of plaque, the patient will often present asymptomatically. They won't have any problems. Because of the risk factors that we're going to discuss in the very near future, they end up getting lipid deposits of these plaques, but it isn't until those plaques rupture and cause a thrombus, occluding a portion or the entire vessel, that you actually start to experience myocardial ischemia. When they rupture, the plaques create a thrombus that occludes the artery, and this affects the supply needed where oxygenated blood simply cannot reach the myocardium and nourish the heart muscle. And I want you to know that this is the most common cause of life-threatening ACS. What's ACS? ACS is acute coronary syndrome. Other causes include coronary artery embolism, vasospasm of the coronary arteries, arteritis, and even sometimes coronary artery dissection. So I'm going to talk a little bit about the risk factors. And this particular slide illustrates the different types of risk factors with ischemic heart disease. Some of them are controlled, meaning we can actually make changes in our behavior that will help reduce these risk factors. And some of them are uncontrolled. So as you can see on the left column, the controlled risk factors include cholesterol intake. Now, cholesterol intake isn't simply just cholesterol. We've often heard the good cholesterol versus the bad cholesterol being LDL, and good cholesterol being HDL, low-density lipids versus high-density lipids. Tobacco. Tobacco can include cigarette smoking, chewing tobacco, dip. These are risk factors that increase your chances of getting ischemic heart disease. Diabetes is considered a cardiac disease equivalent, and I'll discuss a little bit what that means in more detail. Hypertension, elevated blood pressure, or an uncontrolled elevated blood pressure causes stress onto the vascular system, the coronary arteries, and is one of the controlled risk factors for ischemic heart disease. Obesity. Patients oftentimes come in, not understanding why they're having heart attacks or why they have heart disease, yet they have poor eating habits. They can't control their excessive portion sizes, and poor nutrition in general lead to or are one of the risk factors that leads to ischemic heart disease. And also sedentary lifestyle, lack of exercise, but consistent exercise on a daily basis is one of the risk factors. But you can't control your family history. Patients who have a family history of an immediate family member who had heart disease at a young age are at risk for ischemic heart disease. Gender comes into play. Go into details, male versus female, who has more of a risk and at what age. And also age. At what age do patients tend to have a higher risk of attaining ischemic heart disease? So we'll go through these one by one and elaborate in detail the important concepts that you need to know for the Step 2 examination and for treating patients in general. So we've all heard of good cholesterol versus bad cholesterol. And bad refers to LDL, whereas good refers to HDL. The USMLE is very specific about goals, and these can be easy points on the exam if you know them. So I want you to focus on this slide in particular because there's some values and numbers that will help you navigate and be able to recall quickly when you're asked these questions on the exam. Given that these are risk factors, it's important to know that decreased HDL is associated with an increased risk for ischemic heart disease, and an increased LDL, along with increased triglycerides, also increase your risk for ischemic heart disease. And I have an asterisk here by LDL saying that it's a very important risk category for heart disease. What are your goals? So in patients who have a high risk for ischemic heart disease, you want to keep your level below 70 milligrams per deciliter. And patients who are at very high risk are patients who have known ACS, acute coronary syndrome, or diabetes mellitus, or those with already a diagnosed heart disease. In those patients, it's very important when you do your lipid profile that their LDL level is less than 70 and that you tailor your medications to bring their level down to that level. In other patients who have risk for ischemic heart disease, the goal is a little bit less intense, and the goal is less than 100 milligrams per deciliter. HDL, the goal for HDL, remember this is the good cholesterol, and you want that to be greater than or equal to 40 milligrams per deciliter. And last but not least, triglycerides, your goal, you want that to be less than 150 milligrams per deciliter. These are values that I want you to etch into your brain, but not just by simply rote memorization. Try to understand the concept behind it and understanding that very high-risk patients have different goals than patients who are simply at risk without ACS, diabetes, or a diagnosed heart disease. Tobacco. Tobacco is becoming more of a problem today as a risk factor because the traditional methods that people used to inhale or chew tobacco are changing, they're evolving, and one of those big changes are in hookah, where there's a lot of misinformation about hookah smoking and that it's not as bad as tobacco. So to make things simple and the bottom line, hookah smoking is going to be an equivalent to cigarette smoking in terms of your risk for ischemic heart disease. It's not beneficial. It's no less harmful than traditional cigarette smoking. And this is a problem that we're trying to prevent globally with misconceptions of risk. But you also don't want to forget about secondhand smoking. Secondhand smoking also increases risk for those around the patient, and that poses a greater level of risk than those who don't smoke at all. So, if someone is an innocent bystander who is exposed to secondhand smoke, they are at an increased level of ischemic heart disease than people who don't smoke at all. It's one of the big reasons why many restaurants today have banned smoking altogether in the United States. Hypertension. So, hypertension is a risk factor that's going to lead to myocardial infarction. It'll lead to cerebral events like stroke or transient ischemic infarction. It also will lead to organ failure like renal failure and heart failure. So, hypertension, although it leads to an increased risk in ischemic heart disease, is also multi organ, it affects multiple organs, as mentioned previously. Obesity. So obesity is a problem in two ways. I like to call them double whammies because obesity will actually increase your bad cholesterol, which is your LDL, but perhaps even worse, it lowers your good cholesterol, your HDL. So that's a double whammy. It's doing two things that are working against um, prevention of ischemic heart disease. Obesity will also lead to stroke, insulin resistance, so patients have an increased risk of getting diabetes. Leads to hypertension, which in and of itself is a risk factor for ischemic heart disease. And as I mentioned, the double whammy, increasing LDL and lowering HDL. So diabetes mellitus has nothing to do with a motorcycle, but this motorcycle looks pretty cool anyways. Diabetes is going to be an increased risk in blood glucose and insulin resistance that leads to ischemic heart disease. Remember that I mentioned diabetes is considered a heart disease equivalent. Patients who have diabetes are already at a tremendous risk of an underlying ischemic heart disease. And as a clinician, as you're treating a patient's blood sugar and trying to keep it at a normal level, a cardiac workup is something to keep in mind because it's considered a heart disease equivalent. Well, now we're moving on into the uncontrolled, right? These are factors, risk factors that you cannot control in terms of ischemic heart disease risk. And one of them is hereditary. You can see our family tree here. Your family history of premature diagnosis of heart disease is going to be less than 55 in male relatives and less than 65 in female relatives. What does that mean? So if you have a family member, right, and you're a male, and that family member, you have a family member, immediate family member, father, grandfather, etc., who has ischemic or had ischemic heart disease and got it early on in life, at an age of less than 55, then you have a significant family history for ischemic heart disease, and your risk of attaining or having ischemic heart disease is increased as a result. Same goes for females, but the age is different. The age is 65. So typically, higher age in females will lead to increased risk if you have a family member with that particular ischemic heart disease family history. Gender. So we'll keep this simple. The prevalence is that male patients are at higher risk than females for ischemic heart disease, and males typically have symptoms earlier on in life than females, as was discussed in the age risk factor section. And here we have age again. So age, you have a higher percentage. Those who die from heart disease are older than 65. More time for atherosclerosis to build up in vessels. So age is one of those uncontrolled life risk factors that will lead towards ischemic heart disease. So this slide, what I've tried to do is simplify things into compartments and provide it in a way that, again, will allow you to understand things and to be able to recall information quickly when asked about it on the exam. So in ischemic heart disease, we can look at it into two components. Now, rewind 5 or 6 slides, or even more slides, to the image of the coronary artery vessel, right, that was clear, and also the vessel to the right-hand side of it that had atherosclerotic plaque. Now remember that atherosclerotic plaque, patients can be asymptomatic with that. You don't have any rupture of the plaque, it's building up, people go about their lives, they go for runs, they have the plaque there, but without any thrombotic uh, uh, or embolic events, you're going to be asymptomatic. But when does it become clinically symptomatic? Well, it can be clinically symptomatic when a plaque ruptures, and when that plaque ruptures, you can have an unstable angina, or you can have a ST elevation MI or a non-ST elevation MI. That's going to be for a separate lecture and discussion. But what can also happen is that you can get the demand ischemia that I mentioned previously, where the demand simply outweighs the supply of nutrients, oxygenated nutrients, going to the cardiac muscle, the myocardium. And as a result, you get something what we call demand ischemia, and that's stable angina. I'm going to go through that in very much detail here, but I want you to look at this overview slide. So ischemic heart disease can be clinically asymptomatic or become clinically symptomatic. And within the clinically symptomatic category, you can have ACS, acute coronary syndrome, stable angina, which is going to be the focus of this lecture, ST elevation MI, which also the acronym is STEMI, and non-ST elevation MI, or NSTEMI. So let's go ahead and get started and try to make this complex topic bearable and understandable so that we can recall information easily. So myocardial ischemia, you have your supply and you have your demand, right? And this is what keeps the homeostasis, is what keeps balance for our heart muscle, and our heart muscle is nourished by oxygenated blood coming via our coronary arteries. So that's when we have balance. What happens when we have imbalance? When you have imbalance, you get chest pain that will also coincide potentially with EKG abnormalities. Anatomical changes of the heart muscle can also result. So now, with an increase in demand, right, with these lipid deposits in the plaque, let's say somebody goes for a run. Let's make it simple. In cases of atherosclerosis, and you have a situation of poor supply, right? But if you increase demand by exercise or stress, that increased demand will lead to ischemia, and that is what is most responsible for cases of stable angina. And remember, this is a form of demand ischemia. So when you get a question about stable angina or angina, however you pronounce it, or demand ischemia, remember this slide where you have an increased demand. And that increased demand, whether it's you're running or exercising or hypotensive, leading to more demand on the heart muscle, or what you're going to have is a case of demand ischemia, or otherwise known as stable angina. Think of a person who has an underlying risk factor discussed before. He's got one or more of the risk factors. They don't feel anything at rest. They think life is great. Someone tells them to go run 5 miles to raise money for cancer cure, and after the first 5,000 steps, they experience chest pain. What kind of ischemia is this? This is demand ischemia. This is stable angina. What's happening is that the myocardium during exercise of low supply, such as atherosclerosis, is leading to this type of angina. I hope that's clear. So again, myocardial ischemia, we're talking about stable angina. Remember that demand ischemia of myocardium with low supply. Again, I gave the example of a hypotensive patient in the operating room. I see this oftentimes with patients who have ischemic heart disease, And as an anesthesiologist, they're in the operating room. It's absolutely essential that I don't allow them to get too hypotensive. Make sure that there's a balance between their supply and their demand, particularly after induction of anesthesia, which is when we give medications to make them going off to sleep, or trauma where excessive blood is lost. You want to beware of intraoperative ischemia. Okay. There's also the case of the dehydrated woman playing tennis and getting heat stroke. This could be leading to increased demand on the heart. In the case of the chronically anemic cancer or renal patient whose anemia leads to more demand, leading to stable angina. So I'm trying to give you different examples that can be thrown your way that gives you an idea that the patient may actually be having myocardial ischemia, and in particular stable angina, which is a demand ischemia. Okay? Again, exercise, hypotension, and anemia. These are three causes, and I gave you three scenarios to help you remember those particular instances that could be leading to stable angina. Myocardial ischemia. Okay, we're still on this topic of stable angina. How are you going to make the diagnosis? So you have an EKG, and this needs to be done first. This will give you a baseline understanding of what's going on to help you distinguish between whether the patient perhaps is having a heart attack, an ST elevation MI, or a non-ST elevation MI, which is going to involve other tests. An exercise stress test. This can either be done via exercise on a treadmill, but in patients who are unable to tolerate exercise, there are other methods that can be done, and that's given through dobutamine or a nuclear stress test. And then the most invasive form of diagnosis for this would be a cardiac catheterization. This is an invasive procedure which will be discussed in more detail later on. A little bit more about the stress test. The treadmill, and the treadmill is the most common when you suspect a demand ischemia. It's what's the benefit of doing an exercise stress test is that it's done in a controlled environment where you can analyze the effects of increased oxygen demand on the heart muscle. And as I mentioned, how is more of a step 3 and beyond type of concept. So I don't want to waste time and go through those details here. Just understand that it is a essential tool in the diagnosis of stable angina. Okay, so go back and review these slides. This is the end of part 1 for ischemic heart disease. Part 2 will focus on ST elevation MI, non-ST elevation MI, and unstable angina. My intention is to help simplify these concepts, but also help you look at it from a big picture, bring it down, and then focus on the details and be able to recall it for easy points and easy success on the USMLE Step 2 examination. Thank you for your time, and I'll see you for the next lecture.